Hi, let us read about cancer of the larynx. Cancer of the larynx is a malignant tumor in the larynx, that is voice box. It is potentially curable if detected early. It represents less than 1% of all cancers and occurs about 4 times more frequently in men than in women, and most commonly in persons 50 to 70 years of age. Carcinogens that have been associated with the development of laryngeal cancer include tobacco, smoke, smokeless, and alcohol, and their combined effects. Exposure to asbestos, mustard gas, wood dust, cement dust, tar products, leather, and metals. Other contributing factors include straining the voice, chronic laryngitis, nutritional deficiencies, especially riboflavin, and family predisposition. A malignant growth may occur in three different areas of the larynx: the glottic area, vocal cords; supraglottic area above the glottis or vocal cords, including epiglottis and false cords; and subglottis, area below the glottis or vocal cords to the cricoid. Clinical manifestations: hoarseness of more than 2 weeks duration is noted early in the patient with cancer in glottic area. The voice may sound harsh, raspy, and lower in pitch. The patient may complain of a cough or sore throat that does not go away, and pain and burning in the throat, especially when consuming hot liquids or citrus juices. A lump may be felt in the neck. Later symptoms include dysphagia, dyspnea, that is difficulty breathing, unilateral nasal obstruction or discharge, persistent hoarseness, persistent ulceration, and foul breath, cervical lymphadenopathy, unplanned weight loss, a general debilitated state, and pain radiating to the ear may occur with metastasis. Assessment and diagnostic findings. An initial assessment include a complete history and a physical examination of the head and neck. This will include assessment of risk factors, family history, and any underlying medical conditions. An indirect laryngoscopy using a flexible endoscope is initially performed in the otolaryngologist office to visually evaluate the pharynx, larynx, and possible tumor. Mobility of the vocal cord is assessed. If normal movement is limited, the growth may affect muscles, other tissues, and even the airway. The lymph nodes of the neck and the thyroid gland are palpated to determine spread of malignancy. If a tumor of the larynx is suspected, on an initial examination, a direct laryngoscopic examination is scheduled. This examination is done under local or general anesthesia and allows evaluation of all areas of the larynx. Samples of the suspicious tissue are obtained for histologic evaluation. Because many of those lesions are submucosal, biopsy may require that an incision be made using microlaryngeal techniques or using a CO2 laser to transect the mucosa and reach the tumor. Computer tomography and magnetic resonance imaging (MRI) are used to assess regional adenopathy and soft tissue and to help stage and determine the extent of tumor. MRI is also helpful in post-treatment follow-up in order to detect the recurrence. Positron emission tomography (PET scan) may also be used to detect recurrence of a laryngeal tumor after treatment. Medical management. Treatment of laryngeal cancer depends on the staging of the tumor, which includes the location, size, and histology of the tumor, and the presence and extent of cervical lymph node involvement. Treatment options include surgery, radiation therapy, and chemotherapy. The prognosis depends on variety of factors: tumor stage, the patient's gender and age, and pathologic features of the tumor, including the grade and depth of infiltration. Surgery and radiation therapy are both effective methods in early stages of cancer of the larynx. Chemotherapy traditionally has been used for recurrence or metastatic disease. It has also been used more recently in conjunction with either radiation therapy to avoid a total laryngectomy or preoperatively to shrink the tumor before surgery. A complete dental examination is performed to rule out any oral disease. Any dental problems are resolved if possible prior to surgery. Surgical management. Depending on the location and staging of the tumor, four different types of laryngectomy are considered: partial laryngectomy, supraglottic laryngectomy, hemilaryngectomy, and total laryngectomy. Partial laryngectomy. A partial laryngectomy, laryngofissure thyroidotomy, is recommended in early stages of cancer in the glottic area when only one vocal cord is involved. A portion of the larynx is removed along with one vocal cord, and the tumor all other structures remain. The airway remains intact and the patient is expected to have no difficulty swallowing. The voice quality may change or the patient may be hoarse. Supraglottic laryngectomy. A supraglottic laryngectomy is indicated in the management of early stage. It is stage 1, supraglottic, and stage 2 lesions. The hyoid bone, glottis, and the false cords are removed. The true vocal cords, cricoid cartilage, and trachea remain intact. A tracheostomy tube is left in the trachea until the glottic airway is established. It is usually removed after few days of the stoma is allowed to close. Nutrition is provided through the nasogastric tube until there is healing, followed by the semi-solid diet. Post-operatively, the patient may experience some difficulty swallowing for the first 2 weeks. Aspiration is a potential complication since the patient must learn a new method of swallowing, supraglottic swallowing. The chief advantage of this surgical procedure is that it preserves the voice. Even though the quality of the voice may change, speech therapy is required before and after surgery. The major problem is high risk for recurrence of the cancer. Therefore, patients are selected carefully. Hemilaryngectomy. A hemilaryngectomy is performed when the tumor extends beyond the vocal cord but is less than 1 cm in size and is limited to the subglottic area. It may be used in stage 1 glottic lesions. In this procedure, the thyroid cartilage of the larynx is split in the midline of the neck, and the portion of the vocal cord, one true cord and one false cord, is removed with the tumor. The arytenoid cartilage and half of the thyroid are removed. Total laryngectomy. A total laryngectomy is performed in the most advanced stage, stage 4 laryngeal cancer, when the tumor extends beyond the vocal cords, or for recurrent or persistent cancer following radiation therapy. In a total laryngectomy, the laryngeal structures are removed, including the hyoid bone, epiglottis, cricoid cartilage, and 2 or 3 rings of trachea. The tongue, pharyngeal walls, and the trachea are preserved. A total laryngectomy will result in permanent loss of the voice and a change in airway. Radiation therapy. The goal of radiation therapy is to eradicate the cancer and preserve the function of the larynx. The decision is to use radiation therapy is based on several factors, including the staging of the tumor, usually used for stage 1 and stage 2 tumors as a standard treatment option, and the patient's overall health status, lifestyle including occupation, and personal preference. Excellent results have been achieved with radiation therapy in patients with early stage 1 and 2 glottic tumors when only one vocal cord is involved and there is normal mobility, moves with phonation, and in small supraglottic lesions. One of the benefits of radiation therapy is that patients retain a near normal voice. Radiation therapy may also be used preoperatively to reduce the tumor size. The complications from radiation therapy are a result of external radiation to the head and neck area, which may also include include the parotid gland responsible for mucus production. The symptoms may include acute mucositis, ulceration of the mucous membranes, pain, xerostomia, that is dry mouth, loss of taste, dysphagia, fatigue, and skin reactions. Later complications may include laryngeal necrosis, edema, and fibrosis. Speech therapy. Speech therapy. The loss of alteration of speech is discussed with the patient and family before surgery, and the speech therapist conducts a preoperative evaluation. During this time, the nurse should inform the patient and family about methods of communication that will be available in the immediate postoperative period. These include writing, lip speaking, and communication or word boards. A system of communication is established with the patient. The three most common techniques are laryngeal communication or esophageal speech, artificial larynx, that is electrolarynx, and transoesophageal puncture. Training in these techniques begins once medical clearance is obtained from the physician. Esophageal speech. The patient needs the ability to compress the air into the esophagus and expel it, setting off a vibration of the pharyngeal esophageal segment. The technique can be taught once the patient begins oral feedings approximately 1 week after surgery. First, the patient learns to belch and is reminded to do so an hour after eating. Then the technique is practiced repeatedly. Electric larynx. If esophageal speech is not successful or until the patient masters the technique, an electric larynx may be used for communication. This battery-powered apparatus projects sound into the oral cavity. When the mouth forms words, that is articulated, the sounds from the electric larynx becomes audible words. The voice that is produced sounds mechanical and some words may be difficult to distinguish. The advantage is that the patient is able to communicate with relative ease while working to become proficient at either esophageal or tracheoesophageal puncture speech. Tracheoesophageal puncture. The third technique of laryngeal speech is tracheoesophageal puncture. This technique is the most widely used because of the speech associated with it most resembles normal speech. The sound produced is a combination of esophageal speech and voice and is easily learned. Nursing interventions. Teaching the patient preoperatively. The nurse answers questions about the nature of the surgery and reinforces the physician's explanation that the patient will lose the ability to vocalize but that rehabilitation program is available. Reducing anxiety and depression. Any patient undergoing surgery may have many fears. In laryngeal surgery, these fears may relate to the diagnosis of cancer and may be compounded by the possibility of permanent loss of voice and disfigurement. The nurse provides the patient and family with opportunity to ask questions, verbalize feelings, and discuss perceptions. During the preoperative or postoperative period, a visit from someone who has had laryngectomy may reassure the patient that people are available to help and that rehabilitation is possible. Maintaining a patent airway. The nurse promotes a patent airway by positioning the patient in the semi-Fowler's or Fowler's position after recovery from anesthesia. The nurse encourages the laryngectomy patient to turn, cough, and to take deep breaths. If necessary, suctioning may be performed to remove secretions. The nurse cleans the stoma daily with saline solution or another prescribed solution. If crusting appears around the stoma, the nurse removes the crust with sterile tweezers and applies additional ointment. Wound drains may be in place to assist in removal of fluid and air from the surgical site. The nurse observes, measures, and records drainage. When drainage is less than 50 to 60 ml per day, the physician usually removes the drains. The laryngectomy tube may be removed when the stoma is well healed within 3 to 6 weeks after surgery. Promoting alternative communication methods. Understanding the patient's postoperative needs is critical. Alternative means of communication are established and used consistently by all personnel who come in contact with the patient. For example, a call bell or a hand bell may be placed within easy reach of the patient. If the patient cannot write, a picture, word, phrase, board, or hand signals can be used. The nurse works with the patient, speech therapist, and the family to encourage use of alternative communication methods. Promoting adequate nutrition. Postoperatively, the patient may not be permitted to eat or drink for 10 to 14 days. Alternative sources of nutrition and hydration include intravenous fluids, enteral feedings through a nasogastric tube, and parenteral nutrition. Once the patient is ready to start oral feedings, the nurse explains that the thick liquids will be used for first because they are easy to swallow. The nurse instructs the patient to avoid sweet foods which increase salivation and suppress the appetite. Solid foods are introduced as tolerated. The nurse instructs the patient to rinse the mouth with warm water or mouthwash and to brush the teeth frequently. The nurse observes the patient for any difficulty swallowing, particularly when eating resumes, and reports its occurrence to the physician. Promoting positive body image and self-esteem. Disfiguring surgery and an altered communication pattern are a threat to a patient's body image and self-esteem. A positive approach is important when caring for the patient. Promoting self-care activities is part of this approach. It is important for the patient and family to begin participating in self-care activities as soon as possible. Monitoring and managing potential complications. The immediate potential complication after laryngectomy include respiratory distress and hypoxia, hemorrhage, infection, and wound breakdown. Respiratory distress and hypoxia. The nurse monitors the patient for signs and symptoms of respiratory distress and hypoxia, particularly restlessness, irritation, agitation, confusion, tachypnea, use of accessory muscles, and decreased oxygen saturation on pulse oximetry. Any change in the respiratory status requires immediate intervention. Obstruction needs to be ruled out immediately by suctioning and having the patient cough and breathe deeply. Hypoxia and airway obstruction, if not immediately treated, are life-threatening. The nurse contacts the physician immediately if nursing measures do not improve the patient's respiratory status. Hemorrhage, bleeding at the surgical site from the drains or with tracheal suctioning may signal the occurrence of hemorrhage. The nurse should notify the surgeon of any active bleeding immediately. Bleeding may occur at a variety of sites, including the surgical site, drains, or trachea. It is important to monitor vital signs for changes, particularly increased pulse rate, decreased blood pressure, rapid deep respirations. Cold, clammy, pale skin may indicate active bleeding. Infection. The nurse observes the postoperative infection. Early signs of infection include an increase in temperature and pulse, a change in the type of wound drainage, or increased areas of redness and tenderness at the surgical site. The nurse reports any significant change to the surgeon. Wound breakdown. Wound breakdown due to infection, poor wound healing, or development of a fistula, or as a result of radiation therapy or tumor growth can create a life-threatening emergency. The patient must be monitored carefully and identified as being at high risk for carotid hemorrhage. Promoting home and community-based care. Teaching patients self-care. The nurse also reassures the patient and family the most self-care management strategies can be mastered. The patient will need to learn a variety of self-care behaviors, including tracheostomy and stoma care, wound care, and oral hygiene. In addition, the nurse instructs the patient about the need for safe hygiene and recreational activities. Tracheostomy and stoma care. The nurse provides specific instruction to the patient and family about the what to expect from the tracheostomy and its management. In addition, the nurse cautions the patient and family that air-conditioned air may be too cool or too dry and thus too irritating for the patients with a new laryngectomy. Hygiene and safety measures. The nurse instructs the patient and family about safety precautions needed because of structural changes resulting from the surgery. Barbers and beauticians need to be alerted so that the hairsprays, loose hair and powder do not get near the stoma because they can block or irritate the trachea and possibly cause infection. The nurse instructs the patient to drink water and sugar-free liquids throughout the day and to use humidifier at home. Brushing the teeth and dentures and rinsing the mouth several times a day will assist in maintaining proper oral hygiene. Continuing care. The nurse encourages the person who has had a laryngectomy to have regular physical examination and to seek advice concerning any problems related to recovery and rehabilitation. The patient is also reminded to participate in health promotion activities and health screening and about the importance of keeping scheduled appointments with the physician, speech therapist, and other healthcare providers. Thank you.